Okay. All right.
And
Sounds like we're up and running. Thank you, Joe.
just getting the Facebook Live up and running. And as soon as I
All
got
right.
that, we should be good.
Okay, tell me, just say when.
Go on.
Okay. Our tech guru is getting our recording started, everyone. So we'll just be patient for a moment. And I'll warn people, I'm already getting a warning that I need to close some apps because it's affecting my, so anyway, I hope I'll be okay. Okay, thanks a lot, Joe.
No problem.
Welcome everybody to the August meeting of the Autism Society of the Bluegrass. I am Sarah Spraggins. I'm the president of this group, and we will hear from our speakers in just a minute, but we'll do some announcements. We don't have a lot of announcements, but I will say that our next two meetings, our September and October meetings, we're going to be joined again by the people from the Hog Therapy Associates group, and they are going to discuss physical therapy at one meeting and speech therapy at the other meeting. Melanie, is physical therapy first? Do you know which one comes first?
I think it is. I think PT is next. And I think
Okay.
speech therapy is after that, but I can check when I.
Okay. All right.
I
Well,
can
no,
search.
it's no big deal, but so we think that our September meeting, and by the way, our meetings are the last Monday of each month, except for November. The November, December meetings are combined the first Monday of December. So just keep an eye out for that. There will not be a November meeting. But our September meeting, we will discuss physical therapy. And then our October meeting will discuss speech therapy. And we'll be joined by people from Hog Therapy Associates. We do have on our schedule Sunday, October 10th, our Bluegrass Autism Walk, and that is our only annual fundraiser. I think it's still on in person, but the way things are going, I just don't know if I could say beyond a shadow of a doubt. And I really had hoped that we would be back together, and we may still, but I wouldn't be, if I were you, I wouldn't be shocked to hear that we've had to go virtual entirely. We do plan to have a virtual component for it, but if we do meet together, it's going to be back at Whitaker Bank Ballpark, the Legends Stadium. And the benefit to that is there is some shelter while still being outside. And we hope that's enough. I'm just not sure. Not sure right now. And then the main reason I'm not sure is that we'll be inviting people who are not just adults, but a lot of children. And they cannot yet be vaccinated below the age of 12. So that gives me a little pause. And we're just not sure yet what's going to happen with that. But if it does happen, as I say, it'll be at Whitaker Bank Ballpark on Sunday, October 10th, 2 to 5 p.m. And that's husband and Todd Page. Okay. With that said, Joe, Marie, Melanie, Alva, anybody know of any other announcements that we need to put out?
Well, the life course to Alpha, is that something that we can share with the
Well,
group?
yeah.
Yeah, that's actually a partnership between the two groups.
Yes.
Yeah.
And
Charting the life course.
we're looking to have the Charting Life course orientation sometime this fall via Zoom. And then with the actual programming in the late winter, early spring via Zoom.
Mm-hmm. And I'll
Can
say
you hear
what
me?
Go ahead.
No, I was wondering if you could hear me. I can't hear myself.
Yes, we can.
Okay.
One I'll say of that Charting the Life course is it's like some workshops that we've been involved with before, that but it is different. It's not, it is unique, that looks at how to decide these are the things that my loved one with autism is interested in, has an aptitude for, that sort of thing, and then charting the course toward that. So
You look at it.
yeah, I think it sounds really good, and it's going to be involving Carolyn Wheeler. She'll be the presenter for that, but we'll
This
find
is
out.
really kind of an organized way to plan your future. And it's a beautiful thing for our families, communities, not, just particularly about the individual, but also just how we can help everybody get to where they want to be
Mhm. Yeah,
In
it
an
sounds kind of
in an
innovative.
organized way,
All right, if we don't have, Melanie, I'm glad you thought about that. I would have
Yeah.
missed that. And but if anybody else has anything else to announce.
Sarah, the only thing I'm just putting out there is there are big meetings right now at the state legislature in regards to the waiver, the different waivers that many of our families are on, the Michelle P, the SCL, those kind of waivers, and home and community-based waivers. And we've been trying really hard to send out those, the information about those meetings, to make sure everybody knows and understands what might be a possible impact in the future. So just to kind of keep looking either to the Facebook page and or the listserv, because we'll try to keep everybody updated as we get the information. Okay,
All right, thanks, Mel.
sure.
Okay. I think we now can go ahead and hear from our presenters. I will say Dr. Perez. Dr. Perez is going to be joined by presenters in the program from University of Kentucky. And I will probably let you all just go ahead and introduce yourselves. And we appreciate so much your being here. Thank you so much, Dr. Perez. Dr. Christina Perez.
Thank you so much, Sarah. Yes, so I'm Christina Perez, and I am the Pediatric Dentistry Program Director at the University of Kentucky. So I lead these wonderful residents in the teachings of pediatric dentistry. And we are really honored to be able to be here with you guys today. As a pediatric dentist, I've treated children with autism, and I also have a family member that is on the spectrum. So it's close to my heart. And so I can sort of relate in how difficult it is to bring a child, even to be able to get a child to sit in the chair. Yes, I hope that we can help you guys understand what we do, give you some ideas on how we can help kids that have autism with home care, as well as bringing them to the dentist. So we got in touch with the society because within the treatment of our patients on the spectrum, we got in contact with the College of Education, and they have a really wonderful program that's called Applied Behavior Analysis. And so they dedicate to use this directly to the teachings, teaching us how to treat or better treat children with autism. So yes, that's what we're going to try to get that information to you today. So I want to present our residents, and these are second-year residents, so they're and sort of ending their program already. And I'm going to introduce them by their first name because it starts with an I, a J, a K, and an H. So it's sort of perfect. So H-I-J-K. So our first resident is Hunter Hazel. We have Dr. Ivan Wynn, Jesse Martin, and Dr. Kelsey Korb. All these residents are already dentists, but are studying to be more specifically pediatric dentists. So with that being said, I will lead you guys to it.
Is it okay if I share my screen?
Yes, thank you. And I will say to everyone that, as I started to say before, the number of people who are on here tonight is not representative of the number of people who will see this, because we are joined on Facebook Live. And then we also have a really nice YouTube channel that Joe makes sure to populate soon after meetings with recordings of what we see. So we actually have learned that the pandemic is a good thing. We reach more people than we ever used to. So go ahead. Thank you for being here, everyone.
Thank you guys so much for having us. We really appreciate it. As Dr. Perez said, my name is Dr. Wynn. I'm one of the second-year residents at UK. And myself, along with Dr. Hazel, Martin, and Cord, are here to present on autism and dentistry. So the purpose of our lecture is to discuss the role of dentistry in the maintenance of the overall health of patients with autism. First, we just want to go over a basic review of dental decay and infection as a disease process, and then kind of talk about the factors that affect the risk of developing dental decay, and then the clinical signs of infection. And then we want to talk about some of the common dental concerns affecting children specifically with autism, and some of the treatment modalities, some of the home care options that are available to address these issues, and some of the behavior management techniques that can be employed for children across the autism spectrum within the dental office. But before we begin with the presentation, I just wanted to emphasize that some of the information we go over is not necessarily meant to be hard and fast rules. We understand that every child is different, and this is especially true of children with autism. You guys know your children best, and our goal is just to kind of provide parents with a basic knowledge of dental decay and kind of go over the various possible treatment options and techniques for home care to allow you guys to decide which options are best for your child. So I'm going to be presenting on the first part, which is karyology, basically kind of going over dental decay as a disease process, and then kind of going into the signs and symptoms of dental issues, as well as the caries risk factors and protective factors against dental disease. So dental decay, or caries as we call it as dentists, is an oral disease process which can over time lead to irreversible loss of healthy tooth structure. And this is what we refer to as cavities. Dental decay is the most common chronic disease affecting not only children, but also adults as well. And disease is initiated by bacteria, which are found on the surfaces of teeth naturally in the mouth. And they produce acid in the presence of sugar, which is provided by what the child eats. And what they do is they metabolize this sugar and produce acid, which over time will wear away the tooth structure. When the pH in the mouth drops below a critical value, which is 5.5, what happens is there's a net loss of tooth structure, and it takes a while for the mouth to kind of bounce back after this drop in pH. So if you look at this chart over here, once sugar enters the mouth, it immediately drops down to a pH below 5.5, which is this critical pH we're talking about. And then it takes about 20 minutes for it to return to normal after the sugar enters the mouth. And decay progresses over time by chronic imbalances in protective factors and disease factors, which ultimately leads to an unchecked attack of acid on the teeth. So this is kind of a basic progression of tooth decay. Kind of clinically, you can see we start out with a nice healthy tooth that's nice and white. Eventually, bacteria will colonize these grooves, and this is just one kind of decay on the biting surfaces. Decay can also start between the teeth where they contact, and I'll show you kind of images of that later on in the presentation. But this is kind of a typical progression of decay that starts on the biting surfaces. First, it starts out with some staining in the grooves, and then it kind of starts to spread out. Eventually, you'll start to see noticeable loss of tooth structure. You will see kind of this hole in the tooth that starts to form, and then over time, it will just progress more and more until more tooth structure is lost, and it gets deeper and deeper into the tooth. So first, I just wanted to go over kind of the basic layers of tooth structure. First is the outer layer, which is the hardest layer. It's the most mineralized layer and the strongest layer of the tooth, and that's enamel. Then the inner surface of the tooth, the kind of middle layer, is the dentin. Dentin has more organic material in it and less mineralized tooth structure. So once the cavity kind of reaches this point, it starts to spread really quickly because it's just less resistant to the acid. And then the inner layer is what we call the pulp. But basically, it's where the blood vessels and the nerve of the tooth resides. And then the health of this is directly related to what we refer to as whether the tooth is alive or dead. Basically, once the infection reaches this point and travels down out the back of the roots, it starts to affect the vitality of the tooth and causes the tooth to essentially die. So I'm just going to quickly go over the basic stages of disease process. We can kind of break it down into how deep the cavity goes. The first stage is what we call an enamel lesion. You can see this bottom left picture is a very classic representation of cavities that occur between the teeth. It's kind of like this very characteristic triangle kind of structure. And this is it's mostly in the enamel, but it's starting to kind of reach this dentin layer. At this point, there's likely not going to be any symptoms. You're not going to see any noticeable difference. Even as clinicians, when we do an exam, we may not even see any changes to the tooth because it's at the contact area, so it's kind of hidden away. But what we like to call it is these kind of cavities are kind of like icebergs. So you kind of see the tip of the iceberg, and you don't really see much, but when we take an x-ray, we can see it's even, it's more blown out than we thought. So a lot of it is kind of under the surface. And the typical treatment for these kind of lesions are composite fillings and then amalgam, or what we like to call silver fillings. So this is a bite wing x-ray is what we call it. This is kind of a specific view of the back teeth that we like to take at regular intervals during our cleaning appointments. But these kind of give us a good picture of the contacts between the teeth, and it can allow us to visualize if there's any cavities that we can't see clinically at the contact areas. So you'll see in the bottom right-hand side, these two teeth, you can see some shadowing between teeth where they contact. And these are cavities that we would normally not be able to see just looking inside the mouth because they're kind of hidden away. But it's very clear here in the picture that they have cavities that are pretty advanced. And so this is a typical enamel lesion on an x-ray. You can kind of see this kind of shadowing, this kind of triangle shaped shadow. And that's what we refer to as an enamel lesion. So this is kind of a picture of a typical composite filling. So we would go in there and kind of take our handpiece and kind of take away the tooth structure where the cavity is. So just a nice small little preparation. And then we fill it up with a tooth colored filling. So composite fillings are what we like to also refer as tooth colored fillings. Of course, they're very aesthetic and they look nice. They kind of blend in with the rest of the tooth. So they're very nice, but it's really important to keep these dry. So it can be difficult in certain patients to perform these kind of fillings. The other option is amalgam fillings or silver fillings. I'm sure some of you guys have heard of these kind of fillings. Some of you guys may have heard this in association with mercury. It is a mercury compound, but it is perfectly safe. It's FDA approved, and it doesn't really lead to a huge systemic increase in mercury when they're placed. They're very nice, strong fillings, and they're very durable. These are typically reserved for patients where it's hard to get the tooth completely dry to put like a nice white filling in, and also for patients where they tend to grind their teeth. These tend to hold up a lot better than the white fillings because they rely more on mechanical retention than a chemical bond. So the second stage of the disease is dentinal lesions. So you can see it's kind of gotten this triangle area and it's kind of reached this dentinal layer, and it's kind of started to spread out. At this point, they may have some mild sensitivity, especially to hot, cold, and sweets. And especially for baby teeth, at this point, we really recommend a stainless steel crown or a full coverage restoration because baby teeth tend to have thinner enamel, which is that really hard outer layer. And they also have more kind of organic material. Basically, the tooth is a lot softer. Baby teeth are a lot softer and more prone to fracture than adult teeth. So if we try to put a really large white or silver filling on a baby tooth, it's probably not going to last. It's probably going to fracture the tooth. So we want to provide a full coverage restoration to kind of give it some strength. So these are kind of examples of dentinal lesions on a bite wing x-ray. You can see it's still got that characteristic triangle, but then it starts to spread out at this dentinal layer. And you can see it's definitely gotten past the point of that outer white shell of the tooth. And here's an example of a stainless steel crown being prepared on a tooth. These are plastic teeth, but it looks very similar to real teeth. But you can see what we do is we shave the top part of the teeth, the biting surface of the teeth. We shave that down to kind of create some clearance for the silver crown. And then we also make slices between the teeth underneath the gums. And this kind of helps provide us with some clearance so that we can put a full crown on there. And then the bottom left picture shows the crown with some cement inside. So we typically glue this with the cement that kind of releases fluoride, but it kind of keeps the crown on there, but it also releases fluoride to help protect the tooth from future cavities. And then the final picture kind of shows the silver crown fully seated on the tooth, and that's kind of what you would expect after the silver crown is placed. The third stage in dental decay is a lesion that starts to get really close to the pulp. Symptoms in this stage can include constant pain, gum swelling and redness, and you may find that your child starts to hold their face or kind of complains about some pain, and it may be constant. And in this case, we recommend, again, a stainless steel crown, and then in this case, likely a pulpotomy. For baby teeth in particular, this pulp layer where the blood vessel and the nerve is, this red layer, tends to be a lot more exaggerated than an adult tooth. So it kind of is really close to the surface compared to an adult tooth. So once the cavity gets into the dentinal layer, it's not long before it reaches that pulp layer, which is why we recommend a pulpotomy, or what we refer to sometimes as a baby root canal, where we clean out the top part of the nerve and leave the nerve inside the root. And we put some medicine down where we clean out the nerve. And then on top of that, we'll put a silver crown. So this is an example of a lesion that's starting to get really close to the pulp on a baby tooth. You can see how the pulp horns, is what we call it, at the top here, are a lot more exaggerated compared to, say, an adult tooth. But you can see once it gets into this dental layer, it really quickly kind of heads towards that pulp. So here's an example of a stainless steel crown and pulpotomy procedure. So this is the tooth in the upper left, I'm sorry. There's a tooth with a cavity that's pretty large. And then the picture on the right kind of shows after we've cleaned out the cavity and we start to unroof the chamber. Basically, we open up the tooth and show the pulp and kind of clean that out. And then the bottom left picture shows the medicine that's packed in there to kind of seal that layer and kind of protect it from bacterial infiltration. And then on top of that, we'll put a silver crown. So from the outside, it looks the same as if they didn't have a nerve procedure done. It's just that silver crown, so you won't notice any difference clinically. And then the last stage of infection is a pulpal infection. So cavities will likely be visible in the mouth at this point because it's gotten so big that there's a very noticeable amount of tooth structure loss. You should be able to even see it in your child's mouth when they're just opening, not necessarily just in the dental office. The child may or may not feel pain because, like I said, the nerve may be dead, in which case they may not necessarily feel any pain. Gums may swell and bleed. The face may swell, and you may see pimples on the gums. And you may see pus coming from the gums. These are basically signs of infection that have traveled out the back of the tooth. And what it does is it starts to travel through the path of least resistance outside the mouth. So these pimples are kind of a representation of those infections traveling outside into the oral cavity. And they can even develop fever from this as well. Our recommended treatment at this point would be a pulpectomy and stainless steel crown procedure. A pulpectomy is kind of a more in-depth baby root canal, and then a silver crown on top of that, versus extracting the tooth, which is, pulling the tooth if the cavity has progressed to a point where we can't restore it. And you'll see down at the very bottom right, this is kind of a typical occurrence. You'll see shadowing not only around the roots, but also between the roots for baby teeth. And this is because the baby tooth has a lot of these kind of accessory openings for their kind of roots structure, which allows the bacteria to not only go around the back of the tooth, but also between the roots as well. And this is kind of a typical x-ray of a tooth that has gotten to this point where the pulp is infected and basically what we call abscessed. You can see shadowing not only around the roots, but also underneath between the roots. And you can see this cavity is quite large and very clearly into the pulpal layer. So this is an x-ray of a tooth that's had a pulpectomy procedure and then a pulpotomy or a Stencil crown on top of that. So you can see it starts out like this, and what they do is they clean out all the nerve completely, not only the nerve in the top part of the tooth, but also in the roots, and they seal it up with this nice filling material, and then on top of that, they put the silver crown. And then this is the other thing that we can do for this type of situation, which is to extract the tooth. In this case, you can see the root has started to kind of dissolve as a result of that infection. And basically what happens is that infection causes the body to have an inflammatory response. And over time, this inflammation just causes the body to slowly dissolve itself or dissolve the roots and the bone. And in this case, the prognosis to do a pulpectomy is not very good. It's not going to lead to a definitive kind of treatment outcome. And so we would just prefer to extract the tooth in this case. So here are some of the signs of pen abscess, which is kind of signs of a pulpal infection. You can see the gums are clearly very puffy and swollen, and this is a sign of infection underneath that's gathering and building pressure. There may also be what we call periolides or gum boils. Some people call them pimples, bumps on the gums. Another term can be a fistula or a draining sinus tract. But basically, there are these bumps above the tooth that's very clearly associated with a cavity. And you can see in this case on the left side that there's some sort of drainage happening as well. And these are just a sign of infection that's finally pushed through the gums and outside into the oral cavity. And lastly, another sign can be pus. So this yellowish kind of oozy, kind of gooey substance that kind of comes from the around the gums or through a periolus or a pimple. This can also be a sign of infection. So I'm just going to quickly go over the risk factors for cavities. Of course, as we know, sugary and acidic foods and drinks like soft drinks, juices, sports drinks, and even sugar-free drinks, surprisingly enough. Sugar-free drinks, of course, they don't have sugar in them, but they're very acidic still. So even though they're not directly contributing to feeding the cavities, they're so acidic that they still wear away some of the tooth structure. And then, of course, there's foods like candies, fruit, but things you might not necessarily think that might have sugar in them, including gummy multivitamins, nutritional formulas and shakes, and of course, desserts. So we just want to be real careful. Parents, if you guys give nutritional shakes because of their diet, that's fine, but we recommend kind of following up really closely with their brushing and cleaning the sugar off their teeth after they have those shakes. And then, of course, frequency is more important than the total amount of sugar that they receive. It's almost worse to kind of sip on something sugary throughout the day rather than just to chug a large amount all at once. Because if they're sipping on something throughout the day, they're never giving their mouth a chance to fully bounce back from that acidic pH. So it's just constantly wearing away tooth structure, and the pH never gets a chance to bounce back. And then, of course, poor oral hygiene is a risk factor for developing cavities. Medications, surprisingly, can as well. Some medications can have side effects, including dry mouth, and limiting saliva flow can have a profound impact on caries risk because it doesn't allow the body to naturally clear that sugar off of their mouth and kind of buffer that acid. And then finally, habits, things like chewing on certain objects can sometimes put them at a greater risk for fracturing their teeth and opening up those teeth to more cavities. Some of the protective factors that are out there, of course, there's fluoride. Fluoride is very great, and in low amounts, it's very safe. There's fluoridated water, of course. If you live in an area where the water is fluoridated and they drink tap water or sink water, that's great. But also fluoridated water is starting to be incorporated more in manufacturing process. So things like canned goods and juices, things like that are starting to use fluoridated water as well. So you may not even realize that your child is receiving fluoridated water from other sources. Then there's fluoride varnish. That's this kind of middle picture here. There's the red, green, and orange boxes right there. This is what we apply at the end of cleaning appointments. It's very high in fluoride, but it's perfectly safe. It's very sticky. It's meant to be applied directly on the teeth and allow it to sit, to have a topical effect and kind of help remineralize the tooth structure. And we only do this once every 6 months after the cleaning. And then there's fluoride gels and foams. Again, it's kind of similar to idea to varnish. It's a little bit lower concentration, but we find that it's less effective. And sometimes the texture can be an issue for some patients as well. So typically we stick to fluoride varnish. Then there's fluoridated prophy paste. Prophy paste is that kind of special toothpaste we use at cleaning appointments with our spinny toothbrush. But that can also be fluoridated as well. And it has a moderate amount of fluoride in it. And it's just kind of to additionally, add some more topical effect of that fluoride. Then there's toothpaste, of course. Children's toothpaste has typically a slightly lower concentration of fluoride, and it's perfectly safe. If you find that your child swallows a lot of the toothpaste, you can kind of stick to the kids' toothpaste as well to kind of prevent them from receiving too much fluoride. Then there's also fluoride rinses. This green bottle, this is called ACT. There's other brands as well, but this is an example of a fluoride rinse that you can use. And if toothpaste is an issue because of the texture or the taste, you can dip your toothpaste in this fluoride rinse instead and kind of brush it on the teeth and kind of get that topical effect that way instead of cleaning with toothpaste. So this kind of can be an alternative if it's more acceptable to the child. And then there's prescription strength toothpaste. Typically, we reserve this for older children and children that are less likely to swallow the toothpaste. But we can prescribe toothpaste if we find that a child is at particular risk for developing cavities. The higher fluoride amount can kind of protect the tooth from cavities. And then fluoride supplements. This typically we won't use unless a child is really deficient in fluoride or they live in an area where the water is not fluoridated. And typically we would kind of get their fluoride levels before we prescribe this. Then a few other protective factors, of course, proper oral hygiene. We recommend brushing twice a day and flossing after meals. There's certain types of instruments that can assist you guys in cleaning your children's teeth if they need help. There's a toothbrush, a special toothbrush called a Collis curve, but you can see these bristles kind of curve around and they can get all the surfaces of the teeth all at once. You just have to brush on the top of the teeth, and they also get the back, the cheek side and the tongue side as well at the same time. That way you don't have to kind of maneuver your toothbrush all the way around, and you can quickly get kind of clear that sugar off of their teeth. And then for flossing, there's these floss picks that you can use. Of course, I think we're all familiar with these, but they're very convenient and a lot easier than trying to get a whole string of floss in between every contact of the teeth. And then we recommend nothing to eat or drink except water after nighttime brushing. And then, of course, healthy, balanced diet is important as well. Limiting sugar intake. I understand that sometimes this is not the most realistic. Children, and especially children with ASD, can be really particular about their diet. And so if they are, then it's really important that we brush after they eat to clear that sugar quickly. Making sure we limit the consumption of acidic foods and drinks again, and then eating teeth-friendly foods. So there's a lot of foods that naturally have fluoride in them or a higher level of fluoride: hard vegetables, apples, nuts, seafood, honey, and eggs. And then dairy products physically can kind of clean the teeth and clear the teeth really well. Things like cheeses and yogurts are really great for that. But again, with the yogurt, you have to be real careful because a lot of the commercial products have a lot of sugar in them. I'm going to hand it off to Dr. Martin.
Hi guys. Okay, so what I'm covering tonight will be the comorbidities and the medications associated with ASD, and then diet and dental home care. in terms of neurosensory issues and food aversions, things like that. Okay, so what is a comorbidity? The definition is a presence of one or more additional conditions, often co-occurring with the primary condition. So a child with autism may have symptoms of other comorbidities in addition to the core symptoms. Recognizing these medical conditions is important because many of the medical conditions could stimulate or exacerbate the atypical behavior that occurs in children with autism. The other reason is because unwell people who have underlying conditions, they are unable to learn and may lose skills, and basically effective learning for everyone requires a very healthy state. Okay, so what are some comorbidities associated with ASD? Epilepsy or seizures, and that affects about 25 to 40% of children with ASD compared to 2 to 3% of the general population. Sleep disorders or disturbances. Chronic sleep problems affect about 50 to 80% of children with ASD and can include difficulty falling asleep, frequent wakefulness, extreme early rising, and it goes in hand in hand with daytime activities, and lack of sleep makes all of us kind of irritable. So, gastrointestinal disorders, that affects 85% of children with ASD, and then feeding and eating challenges; those two kind of go hand in hand. And examples of this are selective eating and obesity. And then we have our psychiatric comorbidities, ADHD, anxiety, depression. All of these are also commonly diagnosed as well. Okay, so moving on to medications. 58% of children with ASD receive some type of pharmaceutical treatment. Medications are typically prescribed to manage comorbidities rather than ASD itself. Medications can affect oral health in a multitude of ways. Dr. Nguyen kind of hit on those. But one thing that a lot of people don't know or that is not on the ingredient list is sugar, which is frequently a part of liquid medications, cough drops, vitamins, antacid tablets, antifungal agents, things you just don't think about. Okay, so as I alluded to, medications can affect oral health in a multitude of ways, including abnormal bleeding. It can change the rate in which we clot, which is important whenever we take teeth out. It can be taste altering. It can give a bitter or metallic taste, or affect the ability to taste at all. And even NSAIDs and things that you don't think about can contribute to that. It can cause soft tissue reactions. It can make the tissues irritable or stained or a little bit painful and dry. Here I have a picture of enlarged gums. That is known as gingival overgrowth, and it is sometimes associated with anti-seizure medications like phenytoin. But the enlargement of the gums makes a perfect little home for bacteria to kind of live up under there. And so it becomes a cleaning issue. And so you have to clean up under those gums so they don't get irritated. And two, they get really thick and it can postpone tooth eruption. So it's things to be aware of in regards to that. The big one is probably decreased salivary flow, and saliva is our body's natural way of cleansing our mouth. And so when medications suppress that saliva flow, your mouth is not getting the cleaning and the rinsing of the bacteria that it's intended to have. And so it can cause accelerated tooth decay. Okay, so dental home care can be a challenge. A lot of this is or can be due to atypical sensory processing. There's a lot of aversion to toothpaste. It could be the texture or the taste. It could be the sensitivity to toothbrush bristles and the way it feels on their gums and their teeth, or just sensitivity to flossing movements. The invasive nature of oral care may trigger violent or self-injurious behaviors such as temper tantrums or head banging. Head banging as well can be a sign of a headache or a dental or tooth pain. It can have lots of different underlying causes. And then it can be frustrating too, as children may have difficulty communicating their wants or their expectations, or really understanding the point of doing it. Why do I have to do this every day? Okay, so our recommendations are to instill an effective dental care routine by starting at home and starting from a very young age. We even see children, starting at 1 year old or when they have their first tooth, which could be earlier. And we do that to get them acclimated to coming to see us, to show that, it's a good thing, that it's kind of fun to come to the dentist, and then also to get home habits established early. We like to establish a routine. I think, the expectations of brushing your teeth after breakfast and before bed. We recommend brushing with the fluoridated toothpaste to help remineralize and strengthen the enamel. And then if your child is struggling with brushing their teeth, it's always good to experiment with different kinds of toothbrushes, different flavors of toothpaste. As Dr. Wynn said, you can dip it in the mouthwash until you find something that works well for them. Electric toothbrushes, some children hate it, but some children find it almost soothing, the rhythmic vibrations of the toothbrush. So, those are all things we can think about. We like to encourage independence in daily oral hygiene. It's a win if you can check something off your to-do list for, so give them that satisfaction, but you can also go back and check and make sure everything is really good and clean. And consistency with your oral hygiene is always key. So diet plays a role in development of tooth decay, and children with ASD may be a little bit more selective with their food. Food selectivity itself really hasn't been defined in a consistent manner, especially that I could find in any of the literature. But what it really refers to is picky eating, frequent food refusals, a limited repertoire of foods, excessive intake of a few foods, and then selective intake of certain food categories such as carbohydrates, sticky, sweet things, and again, ritualistic eating, things that people may not like stuff on their plate touching, that may be, a turn off for them. It's just lots can go into it. And what contributes to food selectivity would be smell, texture, color, temperature. But what can this lead to, or what does this cause? It can lead to an inadequate intake of nutrients. If you can see this picture right here of this little guy with very red irritated gums, the teeth are clean, and what that actually is a lack of vitamin C. So it's causing a manifestation in the gums that you don't typically see. And again, if there's a selectivity toward high acidic foods like lemons, oranges, sodas, or cariogenic diet. And a cariogenic diet is a substrate that promotes like bacterial formation, and they really grow really well in that condition. It can lead to a higher incidence of tooth decay. And now I'm going to pass it off to Dr. Korb.
Hey guys, so I'm going to talk about like even more ways to prevent caries, and when cavities are present, how to do conservative treatment. I know Dr. Wynn already talked about some treatments, but we're going to talk about alternative conservative treatments to take care of these. So one way to prevent cavities is to, maintain a regular recall schedule. And the recall appointment is just your preventative appointments where you come see us like every 6 months. So many children with autism, like Dr. Martin was saying, they have limited diet preferences like pureed foods. They don't want fruits and vegetables. They only like soft and sticky foods, which obviously puts them at an increased risk for cavity development. They also may have poor oral hygiene at home, just because it's really difficult a lot of times for parents to brush their teeth and keep this oral hygiene up at home, which may necessitate them needing more frequent recalls. And you can see here that American Academy of Pediatric Dentistry, they give us specific guidelines if you're at low, moderate, or high risk, and how frequent your recall schedule should be. And so you can see here, patients with special healthcare needs are automatically put in a moderate risk of caries. And then if they have frequent exposure of, between meal sugar containing snacks or beverages per day, they automatically go to high risk. And sugar, we think of as sweets and like cookies and candy, but a lot of times just like bread, a carbohydrate is sugar. And so lots of patients with autism, they do meet this high risk category. And so again, this is the AAPD, and what they give us for our guidelines if patients are in the low, moderate, or high risk of caries risk. So like I said, patients with autism are automatically in the moderate risk because they have special healthcare needs. And their preventative appointments, just like most typically developing children, they're every 6 months. And, you can see here that with low risk, they can do, every 6 to 12 months and things like that. But for moderate risk, every 6 months, we want to see them. For high risk, you can see we can do a recall exam every 3 months. And this may seem like a lot, and it may be a lot for a parent to bring their child to the dentist every 3 months, but at least, they're getting a good, concentrated fluoride varnish that we only provided our offices, and they are getting a good cleaning or a good exam. And it also gets them used to the dental office as well. So another way to prevent cavities is to do sealants. And so basically you can see in this picture right here on the left that these grooves are like little pits in the top surfaces of teeth really can cause food and bacteria to get trapped inside there. And that just causes that bacteria to grow and increases the risk of developing a cavity, especially if we can't brush it out of there really well. So sealing these grooves in with pit and fissure sealants can prevent these cavities from forming by sealing in the grooves, and those bacteria just can't penetrate down in there. And actually, if you see just a tiny little spot, the dentist will normally be able to see this. That's just a typical, we call it an initial lesion or a white spot cavity. It's basically before it's caused a little hole in the tooth, like Dr. Wynn was saying. You can actually seal over these surfaces to prevent that cavity from growing to getting bigger. And I know a lot of patients with autism like to have their visual, and they want to have like step-by-step guidance of what they're going to be doing. And so this is the steps of how sealants work. This is the tooth without sealants, and then we put an acid edge over the tooth and then we rinse it off, get it nice and dry. We paint the sealant on. We use a little blue light to make it hard, and then afterwards, this is done. Each sealant takes about 50 seconds. It's a really fast process. And we usually do these on permanent molars. So say when the patient is 6 or 7, when they get their first set of molars or 6-year molars, and then again, like when they're like 12, they come on their 12-year molars. And this is just to prevent those cavities from forming in those permanent teeth. And they're also pretty hard to clean back there. But yeah, this is a good way to prevent caries. So this is basically when the child does have cavities, how can we do the treatment as conservatively as possible? So SDF, silver diamine fluoride, is a really good example of this. Dr. Wynn went into some really good examples of like conventional treatment and what we do for typical cavities, but this is another treatment we can always use to kind of prevent the progression of cavities. So what this is non-invasive. It's a topical medicine has a 30% silver diamine fluoride. It's painted on the tooth instead of using a more surgical or drill and fill approach. So as you can see here, the dentist doesn't even use the hand piece or the drill. We just use a little bit of this SDF on a micro brush. And what we do is we brush it on the cavity and then we cover it with a fluoride varnish. What this does is it prevents the progression of caries. So it doesn't cure the cavity. The cavity's not gone, it's still there. It's just really making it really hard and remineralizing it so it doesn't grow and get bigger. So obviously the pros of this are it's quick, easy, and painless. And if the tooth is sensitive, it can relieve the sensitivity of that tooth. It prevents that bacteria. It says biofilm here. That's just bacteria. It prevents it from adhering to that tooth, from that cavity, to make it even bigger. And you can, I'm sorry if you hear my dog in the background whining, by the way. And you can also, you can either avoid or delay more invasive restorations, because if you catch this soon enough and start SD application soon enough, you don't have to do any treatment later on. And it actually arrests or stops the progression of 70% of cavities when it's applied twice a year. So obviously there are cons to silver diamine fluoride. You could see in the previous slide how it turned those cavities really black. So that's permanent. Unless you drill that out with a drill, that black color is not going to go away. And if the cavity is too big, unfortunately, and it's trapping food and causing causing pain, those are typically they're just too far gone, and SDF can't treat those. They would still require a restoration. And then you saw 70% of the cavities are arrested. However, 30% of them continue to grow. So it doesn't work. It's not a 100% foolproof treatment. And like here, it's not a treatment for cavities. It is a treatment for cavities, but it's not a cure. So we can use this to treat cavities, but we're not removing the cavities themselves and putting a restoration in. And then also we need proper diet and oral hygiene to make these, to have long-term success with this. And this is a picture of how it's applied when there's cavities in between teeth, like Dr. Wynn was showing earlier. And the previous picture showed when they're just on the surface of the tooth. And so here's another conservative treatment for when cavities are present. So I'm sure most of you know about silver crowns or silver caps. We call them stainless steel crowns, and they're preformed metal crowns that are adapted to individual teeth and cemented using like a biocompatible. It just means it's, compatible with the body. It glues on there really good. So like Dr. Wynn was talking about, using the conventional technique is the drill approach, where you have to use numbing medicine, which includes an injection, which is usually painful. Use the handpiece to remove the decay, and then you prepare the tooth to fit that silver crown. But using the Hall technique, you're basically just cementing a silver crown on top of a tooth that has a cavity. You're not using local anesthetic. You're not even removing cavities, and you're not preparing the tooth. This was actually started for when, they had like small children that just had maybe 1 or 2 cavities, and they couldn't cooperate in the clinic, and it just like snapped a crown over that tooth that had a cavity. And what it does is it basically seals that cavity from being able to gain nutrients from food, because, that's what bacteria lives on, is what we eat, and sugar and things like that. So if the bacteria in that cavity can't eat off that sugar, then it's not going to grow any bigger. And so obviously there's no really pain associated with this when it comes to like the local anesthetic and stuff, and it's a really quick procedure. However, some children may have discomfort from we have to place a separator band, which I show in the next slide, and they have to kind of bite the crown into place. A lot of times when we prepare the tooth, we make the tooth smaller so the crown easily fits on top of the tooth. But in this case, the crown may not fit the tooth that's perfectly. So they might have their bite might be a little bit open, and then they'll eventually bite it into place where it's comfortable. And so this is a really good picture of the Hall technique. And I've done this on 2-year-olds, I've done this on patients with autism, and it works really well. So what they do is, you see here, we place a little separator, and you can see the cavity on that tooth. After that separator, sometimes all we have to have it in place is for 1 full day or maybe a couple of days. but sometimes even like for 45 minutes, they can, we can come in, put it in, go back to the waiting room, come back and put the crown on, and we have plenty of space for it. And it's a really good technique for patients that they, just cannot tolerate sitting in a chair for a long time and being, using anesthetic and being numb. And it's a really fast procedure too. So then we can just do real quick, even if they don't want to lay down, we can just get it done real fast, and they just have maybe one cavity that we can get taken care of, so they don't have to go through further treatment. Okay, and I'm going to talk about oral manifestations related to autism, but I do want to say, just from those sealants and the Hall technique and things like that, and the SDF, it does still require the patient to be able to kind of either lay down or lay back in our chair, especially with the sealants. The tooth has to be kept really dry. And so a lot of times these may not be options for our patients on the spectrum with autism, because they just cannot tolerate us being in their mouth, and that's okay. These are just options for us to kind of look into if they can lay in the chair and let us be in there for a few seconds, because it is really quick conservative treatment that doesn't require a whole lot. But they do still have to be able to lay in our chair and, let us do the work. So oral manifestations related to autism, and I know Dr. Martin kind of went over this as well. But these oral habits are really high in individuals with autism compared to individuals without autism. And bruxism is just grinding their teeth. This is the most common oral habit related to patients with autism. You may notice that your children with autism grind their teeth a lot, or especially at nighttime. It happens in 20 to 25%. Non-nutritive chewing, so just chewing on their fingers, chewing on their lips and tongues and cheeks. That's very common. A tongue thrust. So when they swallow, if you swallow, you can tell your tongue goes to the top of your mouth or behind your teeth, but more toward the top when you swallow. A lot of times patients with autism, their tongue will go forward. And what that tongue does is it pushes all the front teeth forward, and slowly that constant, swallowing, that constant technique of the tongue moving forward spreads those front teeth out and causes spacing in the little opening that I'll show later. Self-injury, we see this a lot. It's where kids have their fingers in their mouth and they're picking at their gums or biting their lips, which will create a big ulcer. And then erosion. This is basically just the tooth being worn down if patients have acid reflux. In this case, the pediatrician has to be involved to kind of get the acid reflux or whatever is causing that erosion taken care of before we can kind of help the erosion. These habits obviously can contribute to significant dental problems like soft tissue injury, tooth loss, tooth wear, increased overjet and overbite. These are just fancy terms for having their teeth open, or there's too much of a space between their front teeth, or a crossbite in the back. And so these are really great things we can use for these habits. So I found all these two things on Amazon. What they are, they're just soft little sticks, and they have different textures on them, as you can see. And these, like, this hangs on your neck like a necklace. And this is great to try to, get the children to bite on these or use these instead of chewing on their fingers or having their fingers constantly in their mouth. And they're made of like a soft silicone material. So it's not going to damage the gums. It obviously probably could if it's too aggressive with it, but it's better than their fingernails being in their mouth, causing scratches and things. And this is appliance that we can use for that tongue thrust. You can see that the teeth, this patient has braces on, that the teeth are kind of pushed forward, a little flared out. It looks like it's medieval and it's going to cause a lot of pain. But what it is it kind of has these little sharp twines on it, but they're not too sharp. They're kind of blunted toward the end, and it prevents that eventually, that tongue will get used to, oh, we don't want that pain on our tongue, on the tongue. So we're going to put our tongue in the top of our mouth when we swallow. And so it kind of trains them, that muscle to go to where it's supposed to be instead of forward. This could be kind of a tricky thing to do because it has to be glued into the mouth. They have to be able to tolerate getting an impression made, which I'm sure some of you may have had, is a lot of goo in their mouth. So this is something that we can, a patient that's more high functioning autism can probably tolerate. And down here on the bottom, this is a really cool device. It basically goes on their elbow and prevents them from bending their elbow to get their thumb or fingers into their mouth. So it's a total deterrent. They can't even get them in. And then these are also great appliances. If patients have a thumb sucking appliance or they put their fingers in their mouth, it basically just keeps their fingers straight and has that a hard plastic covering on it. So they don't get the satisfaction they would typically get from putting their fingers in their mouth. But yeah, I'm gonna turn it over to Dr. Hazel, and if you guys have any questions, we can answer them at the end.
Hello, I'm Dr. Hazel. I'm another one of the second years. So I'm going to be talking a little bit about applied behavioral analysis. If any parents in here have worked with a specialist in that field, I've probably heard a lot of this before, as well as things to kind of expect at the dental visit and kind of things that we have started doing a little more to make sure our patients are the most comfortable they can be. And then lastly, I'll go over some treatment modalities and ways that we can get the treatment that needs to be done, taken care of in a safe and efficient and happy manner. So basically, applied behavioral analysis helps change behaviors by teaching specific skills. The theory is that by increasing likelihood of the patients who can cooperate for simple procedures, the dentist then can decrease the need for using things like restraints or sedation. So each component of a skill is divided into steps, and then each step is taught separately and repeated, and the child would be rewarded as they learned each skill. So with this method, we can get a child to be very comfortable sitting in the chair by themselves, hopefully getting through other types of tasks that we can hopefully simplify that for them as well. So here's just a generic list of different techniques that, like I said, if you've ever worked with a ABA specialist before, they may talk to you about positive reinforcement, negative reinforcement, generalizing, video modeling, using things like picture exchange communications. All of these things can be used by the specialist, but then also probably encouraged to be used at home as well, so that that child or patient is getting a consistent way of being able to do things. So visual aids are very, very handy, especially in the dental setting when things can be very scary, things are right in your face. So having pictures, I'm going to show you kind of what our ABA graduate program has designed for us that we are able to use. But a book of pictures that can help express desires, observations, feelings is very helpful for not only nonverbal patients, but any patient who kind of wants an image of what is about to happen, you know. So. Here's an example of an appointment schedule. So this is something we might use to show the patient for them to look at while we're talking to the parent. And then we can read through them, show them our utensils while they're looking at the picture, and then kind of slowly, you know, getting through each little step. Some steps we may not be able to get past step 2, and that's okay. But we're gonna, you know, try to go slow, repeat the process, make them comfortable, so that hopefully we can get as much done as possible so that they can have a pleasant dental experience. Communication is very important, obviously, but some of the things that we're wanting to do in a consistent manner is ignore inappropriate behavior by the child, so that they, that's kind of a negative reinforcement idea. Oral commands, giving short, clear, and simple sentences that they can follow. Another thing that goes along with that is sometimes a parent might be asked to be a silent observer in the dental operatory, because it can help ensure that the child is getting one line of, you know, direction and not easily confused. Maintaining good ongoing communication throughout visits and even after the appointment is over. Distractions are incredibly beneficial for every child we see, but watching a cartoon, listening to music, holding onto a special toy. Others examples of this, holding a balloon filled with water, an accordion tube, such as what's pictured, any kind of stuffed animal, any kind of comforting toy or thing that they have that soothes them can really be beneficial in the dental setting when it's a scary new environment. Using sensory techniques. So these are essential in decreasing exposure of auditory and taste stimuli. Having a general introduction to toothbrushing, such as using a washcloth, toothbrushes of different textures and designs. An electric toothbrush may enhance the acceptance of a toothbrush by a child. It may also detract from that. So trying everything and figuring out what works best and what doesn't, it goes a long way. Some other techniques, tell, show, do is something we do for all of our patients as well. We use this to introduce instruments, equipment, procedures, using pictures of radiographic film, disposable plastic mirrors that are plastic, mouth props and saliva ejectors, calling them different names, having a way that is a little more palatable to children or children with autism. Using voice control. This is something that we would obviously want to have a conversation with the parent or caregiver beforehand, because it can rattle a parent if they're not used to another adult talking to their child this way, but can also really help with compliance and help with behavior, because kids can respond really, really well to having a direct authoritative figure saying, you know, eyes to me, look at me, feet straight out. Those kinds of things can really help, you know, give a sense of who the director is in that moment. Positive reinforcement. So this is rewarding certain behaviors, which the idea is that you strengthen the recurrence of that behavior. So one example of that is the presence of a parent during a procedure can be a good positive reinforcer. It establishes appropriate, we're going to want to establish appropriate roles during the treatment, but getting the parent's attention, it can increase compliance. It can decrease negative behaviors, providing effective communication between the dental provider and patient, and then it can also help provide a positive dental experience for the child. Restraints, such as this that's pictured, this is the term for it is a papoose board. We sometimes call it a burrito or a sleeping bag, but these are sometimes employed with challenge patients to obtain safer working conditions and more predictable working environment. So the studies have been found that some autistic children respond really, really well to having tight pressure around their entire body, such as something like a wetsuit. It lets them feel the limits of their body and can have a soothing effect. Whereas sometimes like a light pat can be a tonic to the nervous system and really rattle a child. These are all things that we're going to want to talk about with the parent beforehand before instituting something like this, but they can be very beneficial in increasing compliance and also getting through something that may be pretty difficult for the child. So some things that we're also going to do on our end to modify the way we set up our practice is we think that autistic children should have a patient-centered medical home that provides constant, complete, family-centered, harmonized, empathetic, and culturally effective care. The objectives that we're going to want to achieve are enhancing independent performance of the child, improving community engagement, and then providing support to parents and caregivers in whatever they're needing as well. So this is another example of just an appropriate visual display that can really help a child get a sense first thing about, you know, what may be expected as soon as they enter the operatory. So something that was really beneficial from our end is when the parent calls to schedule their appointment, they can discuss with the front desk staff kind of what their child is potentially needs or things that could be a trigger for a child. Having something like a desensitization visit or just a pre-visit tour where we can introduce dental instruments take them on a tour of the clinic, show them different things, get them used to like what the operatory looks like, maybe have them observe another child in the chair so they can see kind of what that looks like. This is based on classical conditioning. The goal is to diminish any apprehension that's present in the patient. However, this can be a very time-consuming thing. We've worked with ABA graduate program before and had children come in a couple Saturdays where they kind of repeated back and forth between the lobby and the operatory, and we showed them different things. And each time the child would get a little bit better or a little bit more comfortable and be able to feel more confident in that setting. So that repetition can really be beneficial in just seeing it first before they fully experience it. It can help the child understand the events and what to look for during the dental visit. And then using a series of colored photographs, which describe the step-by-step dental visit, can be also really beneficial. And I'll show you what that looks like. So here's some examples of some of the kids that came into our clinic with the ABA specialists. And, you know, you can see we employ a lot of different tactics. We're not doing dentistry in these moments, but we're making the child, we're hopefully making the child feel more comfortable so that they can get to the points where we get to the dentistry stuff. So some other things we're going to do: front desk staff are key in helping a patient's future visits. From the parent perspective, like I said earlier, giving the front desk as much information as possible over the phone can be really helpful. Autistic patients might be disturbed by distracting stimuli, sound, light, taste. If you prefer to have a single operating room, we can definitely accommodate that. That could be really helpful. The goal is to establish trust and develop a relationship and learn what the patient is capable of doing versus learning what the patient is not able to do. Again, having the parent tell us, you know, I'm happy pushing it this far. I'm happy. Let's try that. I think that we can do that. I don't know if we're going to be successful in that. Those kinds of things can really be beneficial from our standpoint. Having short, organized appointments, no longer than 15 minutes of waiting in the waiting room is something we always try to achieve, but especially for our patients who may have a little more difficulty sitting still. And we're also going to want to try to keep the same provider. So any kind of consistency that we can have with your child is really going to hopefully make a difference for them in terms of them being able to get through different things. So our dental assistants are amazing, and they can help identify any kind of triggering points because they're going to be with the patient from start to finish throughout the appointment. So another thing we like to do is just avoid any kind of lateral or quick movements of anything, because that can trigger a child as well. Okay, so, and then lastly, I'm going to be talking about some of the types of adjuncts that we can use to help calm or alleviate any kind of sensitivities or anything like that to get your child through the procedure. So nitrous oxide is the most minimally invasive form of a sedative that we can use. It goes over the nose in a mask that they'll breathe for 5 to 10 minutes to get kind of settled. And then it works very, very quickly. It reaches the brain within 20 seconds. And the depth of sedation can be altered moment to moment. So this allows the person, us administering it, to decrease or increase that level of sedation. And once it's switched off, the gas is eliminated from the body within 3 to 5 minutes. This is commonly used, even adults who are slightly anxious about going to have a dental procedure done. This is sometimes offered to help them get through the appointment. Makes people feel a little lighter, a little sillier. And can really, really help any kind of anxiety and calm the nerves. Oral sedation would be the next version of this. So this can have variable effects on autistic children. Usually a physician is aware of any underlying health problem that could contraindicate this kind of decision, but if a child has minimal dental needs that can be accomplished in 2 operative appointments or less, and they're a child who has the capability of coping through some, getting through some different moments, then they could be a good option for rather than going to the operating room for to get through a few small things. The most commonly used drugs are Versed, Visceral, and Demerol, and then we also add typically the nitrous on top of that to kind of really help calm them. And then this IV sedation. So typically a patient is not aware of this procedure, but is still breathing on his or her own. We rarely do this with children in the pediatric setting, but as autistic patients grow up, this could be a very beneficial way of being able to get their dental treatment done in one of our adult clinics or something like that. But basically, we're going to be putting a thin needle into the vein and sedating them through that way. The IV sedation offers a dentist a very accurate way to administer the effect of the drug. And so this can be really beneficial for patients to get a lot of dental treatment done as well. And then lastly, this is the final way of which we would be able to get treatment done, but general anesthesia is preferred in patients who have difficulty coping with dental treatment in the dental practice. Anesthetic complications are more likely to occur because of the patient's underlying medical conditions. Careful monitoring before, during, and after operating is necessary to minimize any kind of complications or issues, and only an anesthesiologist can deliver general anesthesia. So at all times, at least 3 trained dental personnel, including the doctor, are aware of what's going on, as always keeping checks with vital signs. But this allows us to be able to get through a complete exam as well as complete any dental treatment that they need to be done at one time. So if your child or adult patient has a lot of needs or just has a lot of trouble sitting through a dental appointment, a cleaning of something like that, then this is something we frequently do with patients who have that difficulty. Sometimes what we'll plan to do is do it every 2 to 3 years for a patient. Typically we try to wait 3 years just because we don't want to put people through general anesthesia unless it's absolutely necessary. But that allows us to get a full set of x-rays every now and then and make sure that they're staying healthy, making sure that no baby teeth are staying or no baby teeth are over retained or abscessing or anything like that and causing damage to permanent dentition. And also keeping tabs on how the permanent dentition and those teeth are coming into play. So these are all the ways at which we would be able to get through that treatment. And then that's it. So you can go to the next slide, Ivan. Any questions?
All right, thanks guys. Ivan, if you want to stop sharing. All right.
Do you have any questions on Facebook Live or in the Zoom? You can even put them in the Zoom chat if you don't want to speak up. And we'll ask your question. We'll see it. I don't know.
Nobody has questions.
It was really clear.
It was, I mean, seriously, that was one of the best presentations that we've had in the longest. It was so thorough. Melissa, did you have a question?
I'll ask questions. So a lot of us have kids who are not little like this anymore. And a lot of us have had, some really bad dental experiences in Kentucky, in Lexington. And what are you guys doing to train the dentists who will see our kids over the age of 14 to help improve that experience? Because it's impossible to get an appointment at a UK clinic. And it's really hard to find anyone who has training with a person who is autistic. And, you know, we don't have 4-year-olds anymore.
Yeah, so I'll start, and then residents, you guys can chip in if you like. Yeah, that is a really difficult one. Now in our clinic, although it's pediatric dental clinic, we always say, although we have an age limit for children that don't have special needs, we always try to take care of our older patients, even though, you know, I've got 24-year-old, 25-year-old patients that I continue to see. But I think the thing is that I've been seeing that patient and following them up for years. So it might be different when you want to get a new appointment. And you're right, that would go to the general practice residency because they do sedation of sorts. I don't know if they've received training like we have through this ABA system, which would be ideal. But those are the ones who would be sedating the older children. So yes, that's a complicated one. And what I can tell you is that we are training our residents at this point to see not only children with autism, but adults with autism. And so when they're out there in their practices, they hopefully will be treating not only young children, but also adults with special healthcare needs like autism.
I have a question. You talked about, you know, how that time-consuming process of acclimating someone through the ABA type principles to a practice. Do you think that most practices are open to that? Like letting them come in and view another patient's procedure? Or so do you feel like people don't have to be shy about asking for that sort of access?
I can answer that if you want, Dr. Perez.
Go ahead. I mean, I'll say one word. I hope that as conscious, ethical pediatric dentists, yes, everybody should be able to give their time for that. So go ahead, Kels.
I worked for a dentist in Mississippi who saw a significant amount of in their 20s and 30s special healthcare needs patients. And always, if they wanted to just come to the office to walk around, you know, to look in at a patient taking an x-ray, the doors were open. They didn't even have to call. And now with COVID, it's probably different. Mm-hmm. But like Dr. Perez was saying, surely an ethical practicing pediatric dentist would welcome your children to go in their office to see how it runs.
Well, that's great, and maybe that is a good hurdle to put them past if your dentist isn't willing to allow that. You know, it's not it's automatic. That's an automatic no. It's not the place for your child.
Yeah.
I have a question, and it is: is there any reason that practices cannot advertise that they serve individuals with autism? Because we have to like call dentists and say, do you serve people with autism? And, you know, so I don't know whether, I mean, it would help, I think, young parents when they go looking for a dentist to know that somebody has been trained and is sensitive to this population.
That's true.
Yeah, I don't think there's any reason why they shouldn't put that on their website or information page. What I would tell parents to look for is a trained pediatric dentist, though, because sometimes general dentists, although they might be able to sedate adults and children, don't have, you know, the training that a pediatric dentist does. I would imagine almost 100% of pediatric dentists know about autistic children and how to treat them.
What about if your child is an adult, a young adult, how would you address that? Because I think you were saying that unless a person had been part of your practice when they were a child, you're not likely to take them if they're over 18, I take it. I've had difficulty finding an adult dentist for my son, who's 23, that is sensitive to autism. So how would you go about that? I really like your presentation, by the way. I learned a lot.
Yeah.
And I'm thinking the ABA theory, if the dentist that I have decided on, I'm hoping that they have some training and some familiarity with some of the practices that you mentioned. I like the sealants and a lot of that stuff that I wasn't aware of. So thank you. But go ahead. What do we do for parents that have adult children that are trying to form that relationship with a dentist?
So again, I think I would start with a pediatric dentist, even though they're pediatric. If a patient has autism, I would consider them pediatric patient in my mind. I think the only problem that we deal with there is, what if the treatment that that child requires or that adult requires is a treatment that the pediatric dentist isn't comfortable doing? So I think that's what I run into. So I don't know, root canal treatments on molars, for example, or ceramic crowns, things that we're not used to doing in pediatric dentistry. So a lot of times I sort of buddy up with somebody in the GPR, and maybe the pediatric dentist can refer to an adult dentist in that case, so that together we can work with this autistic patient, providing good treatment with knowledge on how to actually treat a patient that has autism.
We always thought it was kind of interesting that, children grow up to be adults and they're still autistic. So, where does the population go?
I know. Exactly.
I've called several pediatric places, and well, I know at least two that basically said that he is overage.
Mm. Yeah, I get it. Yeah, that's unfortunately really, I don't think it should be that way. And, Dr. Korb was telling us that the person that she worked for had no problem seeing adult patients. So I would say continue searching, and maybe we can come up with a list of names from people in town that, are happy to see older adults that have autism, and, get them through to the society so that you guys get a list.
That would be excellent. Yes. Thank you.
Dr. Perez, I have to share a story. My son's 28, and we did have a very willing dentist when he was a child. We did all the things where we went start low and go slow. And we tried to pair the dentist with a favored activity, even to the point where my husband and I, one of us would sneak in and give a boom box, shows you how old I am, a tablet or some kind of, fun thing to be able to get our son Jay to be willing to go to the dentist. And we got to the point where we got to the office, and we were there, and the dentist walked out, into the hallway and said, and he had the device in his hand, and he says, "Hi, Jay, how are you doing?" And Jay, this was at UK, so we're on the second floor or the third floor, took one look at him and just took off running to the parking lot. And my husband and I were following him, and he went as far as to run all the way to our car. And my husband, we had the key fob so we could unlock the car door, and he jumped in the car and locked the door. So it was like, oh, and the poor dentist was just so lovely. He was so willing to work with us, but our son was just so I don't know, his previous experiences had been so hard. So we now have to do the sedation dentistry. And even that is a very, very difficult thing to do. We get in trouble because we don't do it as frequently as we should, but it's just so hard on our son because it just is such a sensory, this is a very, very hard experience for him. But I thought you would enjoy it. I mean, I'm saying it not to to tease you, but to just it's an embarrassing moment in my life, and I'm not quite sure we ever resolved the issue around dentistry, other than we went to start getting sedation dentistry instead.
Yeah. And I think that's what sort of led us to this. I
Yeah.
can clearly remember the first patient who ran out, and the parent, and it wasn't that long ago, actually. So your son is not the only kid who does this. It's scary. And you know, the mouth is something very intimate. So
Yeah.
for a young baby, it's how they feel the world. So for an autistic child, I think it's just
traumatizing.
overwhelming.
There was a device that years ago, it was Dr. Turner, I think, and I don't even know if he's still at UK, but he used a device that forced the mouth to stay open. It was like you put it in, it was almost like a prong of some sort. And I think that was just so, I mean, and I would feel that way myself if somebody put something like that in my mouth, because, you know, it's from a sensory standpoint. And I think that kind of set the stage for issues for our son for years to come. You know, even to this point, when we talk about if we're reading a story or the word dentist or sneaks into the conversation, he gets very upset, you know, and so we have to be very careful about how we I have to actually, I'm looking around to make sure he doesn't walk in while I'm saying this, but it's kind of part of his world, you know, kind of thing. So finding someone that's sensitive that can help with that transition, because I worry about his teeth. You know, we taught him to floss, and we monitor his brushing, but I'm sure he's got, you know, cavities and that kind of stuff, and we probably don't get as regular dental checkups as we should, just because of it's so hard on him, you know.
Yeah, that makes sense.
I have a question. Oh,
Sorry.
you want to go on?
Question. That's okay.
Well, just so my son is nonverbal, and he's very low functioning. So he has to be sedated. But we take him every year, and you said something about every 3 years. And every year when I have to sign that thing, oh yes, I know this could cause his death. I'm like, getting your teeth cleaned or death? You know, so it's like, okay, you know, he's made it through 46 years of this, so I guess it's okay. But so should we do it every 3 years instead of every year, or you know,
No, I think the reason I say that is because sometimes when we're able to do somewhat of an exam or a clinical check of some kind, we're able to like monitor their home care and like have a discussion with the parents on how they're keeping their kids' teeth clean. Granted, we're working with like 3 to 16-year-olds, and so we don't want to put kids necessarily through an OR experience every year. So I should have clarified that. I apologize.
okay, because he also has his eyes examined and his ears examined at the same time. So it's a real cooperative effort that those worked really well. I was thinking, oh my gosh, maybe I'm doing it too often, and like, okay, all right, thanks.
No, that's a good thing. Yeah.
And I
so-
will add to that, because we do see children, you know, when we do full mouth dental rehabilitation, it's usually on most of their teeth they have in their mouth. And so they're not going to have many more teeth for the next few years because the way they transition and their teeth coming in. So that's why with children, we recommend every few years, because usually when we take them to the OR, we're doing a lot of silver crowns and things that are full coverage, and they're not going to get new cavities on those teeth, hopefully, in the next few years.
I have a question in reference to the sedation. You had mentioned that there were four types, and the last two were the anesthesiologist, if that's what they're called, gave you that. But then the third one was an IV. What's the difference in what they're getting? I didn't understand that.
Right. So IV sedation is going to be administered typically like in a dental office. So that's what good segue into what I was going to say a second ago about when you all are calling doctor's office or dentist offices to find out if your child would be able to be treated there. Something I would look for on their website is something that said like they offer IV sedation or they take patients to the OR. So the OR would be the general anesthesia route, and it involves the use of an anesthesiologist that monitors all the medications that they're using and all their vital signs and everything like that. whereas IV sedation is typically done in the dental office, and it's typically a dentist is doing that themselves. And so they've been trained to monitor those medications and provide that sedation. And it offers a deeper sedation, but it's not always completely fully asleep. Does that make sense?
Yeah, so you're saying that the IV itself is not as deep as the general necessarily.
Mhm.
Okay. And that the general, you're completely asleep and gone. My son's in a situation where he has 3 cavities, and his dentist suggested that he also might need his wisdom teeth pulled because one looks like it's slightly impacted. So the suggestion was that he be sedated and go ahead and get all 7 done and at one time, and then, proceed with replacing or however we chose to go with that. I noticed you all didn't talk about implants, and that's what we're looking at for the front 2 teeth that he's going to have extracted. Again, you probably aren't too many peds that are having to have implants, but he does. So I was wondering, I'm really struggling with it. One, it took us a long time to find an oral surgeon that, one, understood special needs, and 2, would do IV. And I mean, it just was complicated. I didn't quite understand what I was looking for after, really. I think that was probably the biggest problem. But then, so now we think we found a place, and we're just waiting for our appointment because you guys are busy. I don't know. They were saying that part of it is because of COVID, and that, everybody, their mother's trying to get appointments that they didn't get that last year. So everything's been pushed back. And then if you couple that with the unique things that we need as a family, then, it's just really been difficult to get a good spot and a timely spot. So that's an issue. So we go in 3 weeks to have an evaluation with an oral surgeon to see what their recommendations would be based on the 2 dental visits that we've had recently to suggest that he needs to get all 7 pulled. It just seems like a lot. I remember having my wisdom teeth pulled, and I think I must have had local, because I could hear it and everything. I obviously wasn't sedated, and it wasn't a pretty experience. And so I'm kind of trying to figure out what to do about my son, but I think you answered my question.
How many people are in the IV sedation? I know there's an anesthesiologist and like 4 people with the actual sedation with the full sedation. But with the IV, how many people? Is it just the dentist alone?
No, they'll have a dental assistant and sometimes one other person, they'll have a dental assistant, and they'll also have another person in there monitoring the vitals and taking care of all of that. So there'll be 3 people in there that are trained. Yeah. Mm-hmm.
So the difference is that you're getting an anesthesiologist with the general, whereas the other, you're still getting monitored, but you're just not getting monitored by another expense. No, I'm just kidding.
Well, with general anesthesia, the anesthesiologist is breathing for your patient. There's machines that are breathing for your child. The child is not breathing on their own at all. And it takes the anesthesiologist giving them medicine to wake them up. That's where the anesthesiologist comes to play. An IV sedation, technically, the 4 of us are trained in IV sedation. We have our certification to be able to do that. That's just a dentist who has gone through extra training and has gone through several courses to learn to place IVs and to give medications, but the patient can still breathe on his own and be awake, like alerted, like if you shake them really hard. They're not totally asleep.
That's different.
And general anesthesia, the anesthesiologist there's machines that are breathing for the patient. And the patient can't be alerted awake.
Okay, that explains it.
So general anesthesia is usually what we do in your son's case. And a lot of patients with autism can't talk, depending on where they are on the spectrum, can't really tolerate sitting there and letting them watching them place an IV, you know, and sitting still for that. That's really hard. So that's why general anesthesia is usually most recommended compared to IV.
Gotcha.
Although I think they can, it seems like at one point they gave Chris an oral medication that made him kind of get sleepy before they put the IV in, so he would tolerate the IV. So there is a way to do that and to kind of lessen the trauma.
I think it's important to recognize that part of the problem with dentistry isn't just being able to sit in the chair. And it's not just being able to be still and get an IV, but it's also having things inside your mouth.
Mhm.
And oral sensitivity and oral defensiveness is a huge aspect that I think is just completely missed. And you can tie a kid down and crank their mouth open, and they're still going to be completely traumatized when you put something inside their mouths. And I think that the dentistry emphasis on behavioralism, even before we knew the words ABA, is really probably missing what we need to really achieve understanding compliance. And just because a person isn't necessarily verbal or articulate doesn't mean that they can't understand what's happening. And the way that I was educated to participate in my orthodontia was very, very different than the way that my son was treated. And we've, I think by now, been to 6 practices in Lexington and seen some of the people that are on UK staff at their own offices. And ABA is not the whole answer. There's a lot to be said for a gentle approach. There are also these little rubber corners that can go between the molars that can go under a dental dam. And that is a much gentler way to keep a mouth open. And then there are cheek extractors. And I got to tell you, my son, who is 14 and a half, had general anesthesia on Thursday. And all the skin in his mouth peeled over the weekend. And he really only could eat solid food on Saturday. And it's because it took so long. The gauze dried out, the gauze stuck, and he still has a crack in the corner of his mouth. And I think these were like a great team doing their absolute best. And we were not at all prepared for that. And nobody had any advice for us. So, like, you know, it's not just a matter of getting people to be compliant. You also have to fully educate the parents who are going to take this kid away. And if you have somebody who is unversed, they don't remember. And if you have somebody who has impulse control issues when they're not sedated and you give them Versed, and then you hand that person back to somebody who has to go drive in a car with this person, that is just, you know, it's really dangerous. And we have to be much more careful. And if UK is not willing to be the service that all of the private practices in the region think that they are, and to take absolutely every patient who has any sort of special needs or Medicaid, then UK would be better off going into those practices, setting standards, making the ethical guidelines and the moral treatment guidelines so that those practices can improve. Because we were told when we knew that we needed to go for sedation dentistry that we couldn't even start calling back for an appointment until September. And that would be a first-year resident. And because my son is 14, that would not be in the pediatric clinic. And so if we had not begged and we had not called, we would still be waiting. And, you know, we were at the surgery center for 5 hours. We still have to go back for 3 more fillings.
Now, why would 14 not be in the pediatric clinic?
Ask the receptionists who took my calls. Like they're not taking new patients. They are not taking new patients, not in the general dentistry clinic, not in the pediatric clinic. Like, unless you're in there, you can't be seen there. So it is great if you guys are doing this amazing rock star work, and it's wonderful for the kids who are being born now. But there are people in Lexington who need these services, and the practices that are available to us are not equipped or trained to handle our kids. So I think that sort of outreach would be a better focus than just developing this wonderful model for a few people. And I'll be quiet. I'm sorry.
Sorry, I really appreciate your input, and I apologize that your experience wasn't as ideal as you would have wanted it to be. I think one of the frustrating things about navigating care, especially at UK, is at first we need a dentist to get a set of eyes on the patient and kind of figure out exactly what treatment needs they have. Because in our clinic, we're trained primarily to treat baby teeth. So all of our kind of tools are geared towards baby teeth. Whereas the general practice residency, which is next door to us, they're geared more towards adult teeth. Root canals on adult teeth, ceramic crowns, as Dr. Perez was saying. And so getting them in the office, getting x-rays, kind of figuring out what cavities they have or what treatment needs they have is really the first step. And I can understand that it's very frustrating because, yes, we're very booked right now. One part of it is due to COVID, but also part of it is because everyone in Kentucky is referring all their patients to us, specifically certain types of insurance. They're not willing to accept them, and we're one of the few places in all of Kentucky that are willing to accept them. And so we're being inundated with all of these referrals that we have to sort through. And unfortunately, that means that some patients that really need treatment kind of get lost in the shuffle. I assure you, we are trying to work very hard to get through that list and see these patients, these new patients, as quickly as possible. But it can kind of add to that frustration where, you come to our office and we do the evaluation and we determine they have more adult needs, and then we kind of have to refer within the UK system to kind of find the right provider for them. In regards to the front desk kind of giving you that answer where we typically don't see 14 and above, it's because at that point they have all their adult teeth, and so any treatment needs that they have would likely be geared towards adult teeth in general. And in that case, yes, the general practice residency would be better equipped. They have more knowledge in treating adult teeth. They have more materials to treat adult teeth. And that's why typically we make that kind of delineation. But of course, like Dr. Perez was saying, we're happy to see kids well into their 14, 15, even into their 20s. We have a lot of patients that we see that 14, 15, into their 20s that we still see. But it's just difficult when we don't know exactly, as a new patient, what they exactly need to be treated.
So, and I will say that once you get in the system, then you're okay. I mean, you have to make the appointment like 6 months ahead of time. You'll say, when do I go back? And they'll say, you come back in a year. And they'll say, we don't make the appointment for 6 months, but call us in 6 months to make the appointment for 6 months later. But so once you get in the system, you're in and you can make it and everything goes fine. But I think these folks are experiencing the very beginnings of starting out. And I think that's where they're having the problems. Because I really compliment UK's general dentistry. I think they're wonderful. I've been very satisfied with them for years. So congratulations to you all.
If we don't have any more immediate questions, I feel like we should probably let these poor people end their day. You're probably exhausted. You've, I'm sure, had a full day before you joined us tonight, and we really appreciate all the information. And it will have been seen by dozens and dozens of people who will watch it on our YouTube channel. And get a lot of really great information about this. So thank you so much for being with us tonight. I thought it was very, very thorough with a lot of great information. And
Yes, thank you.
Thank you, guys.
Thank
Thank
you for
you so
having us.
much.
yes, thank you, everyone. Have a good night.
Thank you.
Mhm.
Appreciate
Thank you
it.
guys.
Thank you so much for being with us.
Yes.